Noswaith a chroeso. Good evening and welcome everyone. This evening we're very fortunate to have Dr. Lucy Pollock giving this evening's lecture. Dr. Pollock is a consultant geriatrician who trained at the University of Cambridge, St Bart's Medical School and several London hospitals before moving to Somerset in 1997. Lucy chaired her local clinical ethics committee for 10 years and is proud to have contributed to the Medicine for Older People syllabus for Bristol University Medical School, which she confidently believes to be among the most comprehensive, effective and popular undergraduate training in geriatric medicine in the world. Lucy loves high-quality, patient-centered care of older people. She enjoys meeting students and allied health professionals and watching all her trainees learn and discover what it is about geriatric medicine that is so irresistible. Lucy is also made happy by family and friends, birds, plants, reading, music, slow running, and even slower swimming. Lucy has written 2 books, the book about getting older and The Golden Rule. They're both published by Penguin Random House, and I can certainly recommend The Golden Rule, a book of personal stories that is replete with wisdom, humour, practical advice, and tender observation on the process of aging and the care of older individuals. Lucy, it's our great pleasure to have you give this evening's lecture. Thank you.
James, thank you so much. That is a really kind introduction. I'm going to click to share my slides. I hope this is now working, just about, and we'll start from the beginning with any luck. That should be about right. I hope everybody can see me and more importantly can hear me and can see the slides. Fantastic, thank you. So thank you so much to James and thank you to Karen and the team in Cardiff, and thank you all for attending on this gloomy, cloudy, damp, foggy night. And you will see that there's a lot of slides in this, but you're lucky these are very image rich and data poor, so there are lots of photographs. What do I want to say? I have a declaration of interest, which is that I'm not paid by anybody else apart from, luckily, a very nice publisher. And I love Age UK all over the country, but I'm particularly fond of the one in Somerset and the WI. And here we go. We're going to be talking about the ageing society and the ageing population. And what I'd like you to do quickly now is have a look at the person sitting next to you, if you've got somebody sitting next to you, or maybe have a look in your mirror or on your phone and have a good look at that face and ask yourself, are they aging? And the answer is, of course, we are all aging and we are all the aging population, and we are all contributing and will continue to contribute to the incredible increase in the number of older people in this country. And this is something very much to be celebrated. It's the product of generations of research and improvements in social care, medical care, vaccination, clean water, and so on. So, it's important that we get this right. We need to improve what we're doing right now because we clearly haven't got it right. And also, if we're really interested in our own future, we should probably do something about it now. And I just wanted to start with an important number that just illustrates some of these things. So this is a number that you may not know, but what I'd like you to think about is if you're blowing out the candles on your birthday cake, at what age do you have a less than 50-50 chance of reaching your next birthday? So what age are you when suddenly the balance is tipped and you've got a less than evens chance of reaching the next one? And you might be guessing, and if you wanted to, you could put something in the chat, but I think just have a think about what that number might be. My medical students, when I ask them this question, tend to say 82 or 81, something like that, because they're aware that that is approximately average life expectancy in the UK. But that is not the correct answer. It is the average life expectancy, it's not the correct answer. And I put it another way, if you took a party of 90-year-olds, would you expect half of them to be dead by next year? And the answer is no. Lots of them are out there driving old people to appointments. So it's not that either. You have to go even higher. This is based on the UK census data for England and Wales, and it is a good number. It goes higher than that. The actual number is 104. And what that tells you is that obviously it's a statistical trick. Not very many people to live to be that old. The most popular age for women to die, the commonest age at which women die is 89. For men, it's about 87. But it does remind us that lots of people are very much getting older. And that means that I've chosen a very good career in geriatric medicine. And it's one that I would encourage anybody here who's in training in medicine or is interested in the AHPs, you know, are involved in a healthcare related career, do think about doing this. So when I was young, I was sure I did not want to be a geriatrician, and I thought I was probably going to be a surgeon. My very first job, I had this incredibly handsome surgical consultant that I was working for, and I thought, well, this is the glamour. This is what I'm going to do. And one evening in Reading, a long, long time ago, I was allowed to take out somebody's appendix, and that was all very exciting. And I had a very dour Scottish anaesthetist, and it's surprisingly difficult to find an appendix when you have to. And I was rumbling around in this poor person's abdomen, and after a while, this anaesthetist looked over his over his mask, and he said, "Dr. Pollock, is your operation over yet? Because the anaesthetic is." And at that point I thought, okay, right, okay, we have a change of career. And actually underneath, I had always known that I was going to be a physician, not a surgeon. And so I did lots of training in lots of different medical specialties, as you do as a young doctor. I loved all of them. I enjoyed all of them. I didn't know what I was going to do. And then a very sensible older physician said to me, he said, "I hope you won't be offended, Lucy, but I think you should do geriatric medicine." And the minute he said that, I knew that he was right. And I'm very glad, because why? It's a brilliant career. Here's one of my favourite thank you letters from the pandemic. This lovely little girl has got the message. She says, "I'm 6," and she says, "A mask," and she says, "Thank you for looking after my granny." But the most important thing she says at the top, which is a bit difficult to read, she thanks the doctors and nurses and assistants. And I love that a 6-year-old child was able to spot that geriatric medicine is a team game, and that we work together, and we have nurses and physios and occupational therapists and social workers and healthcare assistants and people doing the cleaning and people doing the cooking and the housekeepers and the discharge facilitators, and this huge team of people. And behind that, we have the researchers and the people in social science and the people in the labs, and so many people working out how to look after older people well. We have the best cake of any specialty, obviously, and the most important thing we have is the best patients. So here is a typical outpatient clinic in geriatric medicine. And that means that your patients are very interesting people. They're the rest of us, but grown up and with very good stories to tell. Also, their medicine is fantastically complicated, so it's an intellectual exercise, understanding what might be the matter with them. The science is interesting and complicated. So here are older people out there. They are doing all sorts of things. They're not all unwell and in hospital. They might be out there having fun or in a period of mourning or reflection. You don't have to be happy every day when you're older. They can be having a cup of tea, getting a degree. They could be going on a pilgrimage by a river. They can be going for a pilgrimage in a river. They can be learning a new skill so they can talk to their family all over the world. We saw lots of people doing that during the pandemic. Or they could be trying a new food. And that makes life very interesting because everybody is different. But here are some of the challenges that come along. In the old days, we had a life curve that looked a bit like this. So if you put independence up the side and age along the bottom, you watch your teenagers coming up to being 100% independent, and what you want to be is alive and well, alive and well, alive and well, alive and well, dead. And that is what used to happen. 200 years ago, that was very much what happened. The only hitch was the age at which you died could be 2 years old because you died of diphtheria, or 15 because you had TB, or 21 because you were killed in a mining accident or something like that. So you might be well and then rather suddenly dead of a communicable disease, for example. And of course, that has changed, and we now have this curve of frailty that I often draw for the students. And we have these issues of developing problems that happen in later life that increase our chances of becoming frail. And most of my patients are in the bottom right-hand corner of this graph, or somewhere on that slope. And it's important for me to know where they are. But also really important for all of us to remember that people's quality of life in the bottom right-hand corner can still be good. So lots of my patients who externally somebody else might judge their quality of life as not being very good because they may be housebound and not being able to be very mobile and be quite dependent. Actually, older people often judge their own quality of life much better than an external person would judge it. And it's really important that we recognise that. But also important to recognise when life is actually very tough and to have that conversation about what's going on, and we'll come back to that later. And one of the really big questions for all of us, and Chris Whitty has talked about this very beautifully, is how we square this curve. How do we delay or defer that frailty so that we are alive and well, alive and well, alive and well, dead? One of the ways we can do that, we know that probably the biggest influence of all is socioeconomic. So really, we want to be like the Queen. You want to be fit and well until you're very old and then have a very brief illness and expire. But that is not what happens to lots of people. So lots of the issues are on this slide are very much related to socioeconomic determinants of health. And that's a different lecture, but it's a really important one. But there are lots of other things we can do. And there are lots of books out there about how to live forever. And you will notice that I'm afraid most of them are, it happens to be that most of them are written by men, and they're all about how you don't have to get old. Okay, so plan A is don't get old. And so there's a question of how do you do that? What is probably, apart from the socioeconomic thing, what is the single thing that people can do? There is one free, safe, effective treatment that will not only increase your lifespan, but also compress that morbidity, allow you to stay independent in your own home for longer. And I suspect that many of the people in this audience will know exactly what that is. Because, of course, it is being active. So there is hundreds of studies from all over the world looking at activity and exercise. And this is one of my favourites that was published in the BMJ some time ago, but it was from a huge cohort in Sydney and Australia, where they were doing lots of work on a big cohort of men in their 70s, and they were measuring loads of different things, cognitive function, blood pressure, and so on. But they also measured walking speed. And they looked again in 5 years' time, and what they found was not a single man had died in that huge study who had been walking at speeds of more than 3 miles an hour at the beginning of the study. And as they said, they had discovered the walking speed of the Grim Reaper. Now, that's actually pretty fast, but what we also know is that actually simply moving all of us who are in the bottom quartile of exercise and activity up one notch would make the most phenomenal difference, because really the thing that makes most difference of all to all of my patients is being able to do this. Being able to stand up out of a chair makes a phenomenal difference to your chances of being independent and in your own home. And that's just a tiny increment, but it's absolutely key. So my message really about exercise is great if you're an Olympian and you do marathons and you do another marathon. That isn't going to make a huge difference, though. What does make a difference is if you're not very mobile, not very active, you just do something. And that's lots of us. So if all of us just do a little bit more, stand up during the adverts, move around, try and do that little bit of extra exercise that makes us out of puff every day, that makes the most phenomenal difference. So that's plan A, which don't get old, and then plan B. That's the rest of the talk. Let's talk about it. So what do we need to talk about? There are loads of things that happen for older people that are difficult. There are loads of taboo questions, so they can be contentious. The contentious ones would be something like, my husband shouldn't be driving anymore, but he's not going to listen to me. How do I get him to stop driving? My auntie should be going into a care home, but the only thing she can remember is that she's never, ever, ever going to go into a care home. So there are things that are going to cause a family row. There are things that are embarrassing, like talking about continence, for example. How do you talk about continence to a young doctor who looks like your grandson? And a lot of people don't have the words for those conversations. That's really awkward. Or something can be frightening, and that means that things like, I've had a TIA, a mini stroke, and I am absolutely terrified that the next thing that's going to happen to me is an enormous stroke. And nobody ever tells people in that situation that the vast majority of people who've had a TIA or one stroke do not have another stroke. 9 out of 10 will not have another stroke. but that is a very frightening prospect. Or I've had a fall and I've broken my hip, and I'm really frightened that if I fall and break the other hip, I'm going to end up in a care home, and if I do, it's going to look like the ones on Panorama full of dishevelled old ladies, and I do not want that, and it's a very frightening prospect. And we don't talk about the fact that most care homes are really not like that. They're places of love and kindness and enormous expertise. Or there are things that are socially unacceptable to talk about, which I am going to come to. And one of the big things for older people is trying to work out what is common as you get old and what is normal. And there are lots of things that happen to older people that are very common but are not normal, like falling over, for example, like getting problems with cognition. Dementia is an illness, it is not aging. But it's really hard to work that out. And also, all of us fall into the trap of thinking, I've had a memory lapse and I must be getting dementia. As you get older, if you're young, you don't think that. You think, I've had a memory lapse and it's because I had too much to drink last night and I've got a bit of a hangover, or I've just got too much on my plate, I'm thinking about too many things and I've forgotten something, or I'm quite disorganized anyway and I'm always forgetting things. But as you get older, something happens, like I write in my diary and I open it and it says, let Martin know, and I look at it and I think, I have no idea, not just what I should let him know, but even who he is. Is this normal? How long is it going to take me to retrieve this information? Is this the beginning of the end? So there are questions about that, things like continence. So one of the big questions for older people is when to make a fuss. So that brings us on to our interaction with medicine in older age. And here's another of my favourite pictures. Thank you for looking after my granny so well. Here, take some medicine. The hitch is, if we look more closely at this lady, we can see that perhaps our medicine is perhaps not as popular as we might think. And I think it might be the medicine rather than the condition that is causing this unhappy look on her face. So what is going wrong? I want to talk about medication for a little while. If I said that 1 in 5 surgical emergency admissions was due to a problem with the previous surgeon's procedure, there would be uproar. We know that at least 1 in 10, probably 1 in 5, emergency admissions of people over the age of 65 is related to their medication, of which 80% are preventable. How have we let this happen? So here's one of my favourite handbags. One of my psychiatry friends says you can tell a lot from an older lady from the contents of her handbag. I particularly love this one. It's got both verses of the national anthem, you never know, and a very important packet of pills. And you look at it and think, jeepers, what is going on there? And separating that lady from her pills, I can tell you, was quite an exercise in diplomacy and tact. And I want to show you how things can go wrong easily. So here is a game I play with my medical students. I give them these 5 medications. Now, I hope you can see me, and I might have to ask James to text me if you can't, because I'm going to hold up some medications, these 5 packets of medicines that I show to my medical students, and I say to them, I've got this lady who 2 years ago wasn't taking anything apart from a bit of gentle paracetamol, and now she's taking these 5 medicines, and I'd like you to put them in the order in which they were prescribed. And my medical students look at me and they say, well, there's no dates on the box. And I say, that is because you're meant to work it out. So that's great, you can see me. So the medicines are, there's one called oxybutynin, there's one called amlodipine, there's one called Laxido. No geriatrician goes anywhere without a big box of laxatives. There's some furosemide and there's some ibuprofen. And I can show you what happens, because what happens is, this lady has got some arthritis in her knees, and she's a larger lady and she's waiting for a knee replacement, and it's not going to happen for ages. And the paracetamol was working, but now it doesn't. And she's tried iBelieve gel and that's not working. And after a long discussion with her GP, they decide that she will have some ibuprofen, because it is ruining her life and she cannot move. And lots of you will know some side effects of ibuprofen. We worry about it in older people because it can cause indigestion, it can cause ulcers in your tummy and down your gut, and it's not terribly good for your kidneys. But she's got a cast iron stomach and her kidneys are okay, and she decides she'd like to take it. But we also forget that it actually is a non-steroidal anti-inflammatory drug, and it just increases your blood pressure by a little bit, by 4 millimeters of mercury. And that takes this Mrs. Brooks from a systolic blood pressure of 158 to 162. And any GP in the room will know that that means she's hit the nice guidance target for treating her blood pressure. And here we start her on some amlodipine, which is the first line calcium channel blocker for high blood pressure in older people. And a little while later, she has got ankle swelling, because this drug causes ankle swelling in about 1 in 10 people that take it. And if you're in your 50s and you get that, you tend to go back to your GP, say, my ankles are swelling and I don't want to take that tablet anymore. But if you're an older lady, you go back to your GP and say your ankles are swelling. What often happens is they say, oh dear, are you a bit breathless? And of course she is. She's an older lady who's quite overweight and she's got terrible arthritis and she's going to be breathless. And he says, oh dear, I think you might have a little bit of heart failure, some fluid retention, and here you go, you start some furosemide for that. And before she started the furosemide, this lady was able to get to the toilet because she could just get there on time with her creaky knees, but now she can't because this is making her wee a little bit too quickly, and that means that she goes back to the GP again and she gets this horrible drug called oxybutynin, which is a drug designed to dry up the bladder. It's an anticholinergic drug, and it works for 1 in 9 people who've got an irritable bladder. It doesn't work for the other 8 in 9, who are all getting the side effects, or most of them are getting the side effects, which are dry eyes, dry mouth, dry bowel, and unfortunately dry brain. So we know anticholinergic drugs increase your risk of cognitive dysfunction. And anyway, that is why she's ended up on the laxative. And that is a thing called a prescribing cascade, and it's remarkably common. And it's very easy for us to fall into the trap of prescribing all these tablets, one after another, for the side effects of the previous drug. And there are lots of hitches with medication that are more complicated than that. And some of them come down to how difficult a medication is to take. We change inhalers all the time. They're always inventing new mechanisms, and some of them you have to shake, and some you have to twist, and some of them have to click, and you have to lift the lid or put the capsule in. And this was a new one a few years ago, and it was on Margaret's bedside table, and she was in quite a muddle about the rest of her medicine, so I was a little bit worried about this one, and I hadn't seen it anyway, so I said, oh, it's a new one on me, Margaret, tell me about that. And she said, oh, Dr. Pollock, I love that one. And I said, oh, go on, Margaret, then show me how that works. And she went like this. And at that point, I removed it from her, and my daughter was really cross with me about that. She says, you're a complete hypocrite, Mum, because you say that older people should only have the medicines that make them feel better, and that one was making her feel better. So now I feel pretty bad every time I look at this one. But it just illustrates how difficult these things are. So when I look at my patients' medicines, where do we start? We don't look at a list, because 1 in 3 people will not be taking the medicines that are on the list. We look at, that's beautiful work by a GP called Deb Gompertz down in Somerset here. It's fantastic. If you get your patients to show you what you're taking, we look through them and we see lots of things going on. And here's a very good one. And actually, of course, my patient isn't taking her dog's medicine, but what this tells me is something about what is important to her. So yes, I can look at what she's taking and what she's not taking, but I can also realize that her little dog is so important that she does not want to forget his medicine, and she will put his medicine in with hers in order to make sure that she remembers it. And that is true for lots of my patients. And it brings us on to a conversation about what's important, what matters most, what are your priorities. And often, for a great many of my patients, this is the kind of thing that is a priority. This is a lovely picture from the Northwest. It's not one of mine, but isn't it beautiful? One of the simpler ways for all of us to talk about medicine, or if you're a surgeon, to talk about surgery, or if you're a pathologist, to talk about doing a blood test, or if you're a radiologist, or if you're a patient or a family member, or anybody trying to decide about a procedure or a test or an operation or a medication, we need BRAN. And BRAN is a wonderful acronym that comes from an international campaign called Choosing Wisely. What are the benefits? What are the risks? What are the alternatives? And what happens if I do nothing? And I use this framework all the time. And we have to challenge ourselves not to just say, oh, I'm going to give you this tablet because you're high risk of something. We have to say, how high? How high matters, because what's high for one person isn't high for another. And I just I don't want to talk much longer about this, but I just want to show you a little bit about what can happen and just emphasize some of the science behind this. So this is what I titled this talk, Where Science and Art Coincide. Here's George, he's 91, he's been admitted following a fall, and this is his medical story. Medics always talk in terrible 3-letter acronyms. He's got type 2 diabetes, he's got ischemic heart disease, he's got a long-term catheter, he's got iron deficiency anemia and a leg ulcer. Okay, and here is his medical history, his medication list. This is not unusual for people in their 80s and 90s to have a list like this. And you would think, well, where do I start with that? Okay, where you start is here. You start with George and what matters to him and a little bit about his life and his story. He used to mend everybody's dishwashers. He lives on his own. He's very fragile and forgetful. He's got carers coming in 3 or 4 times a day. Most recently, he's not been eating. He's been losing weight. His bowels are causing all sorts of trouble with accidents, and he's had falls. As it happens, he hasn't had angina for a few years, and let's have a think about what he actually likes. He loves watching telly, and of course he loves the repair shop. And what does he not like? George is very clear about that. He does not like his tablets, and it's one of the things that causes a rumpus between him and his carers. And in fact, he likes being in control of his tablets, and this is how he looks after them. He puts the whole lot in a box, and then he takes 8 a day. So this is a real photo from one of my registrars. And I just want to show you what, as a geriatrician, one might do quite quickly with this. And this deprescribing is informed by a huge body of science behind here. So the amlodipine and ramipril, for example, for his blood pressure, one of his problems is his blood pressure drops as he stands up, but also because he's getting older, his blood pressure is dropping anyway. We know now that your blood pressure starts dropping about 14 years before you die, about 2 years before you're diagnosed with dementia. And we know that postural hypotension, a drop in your blood pressure, predicts dementia. So there's lots of stuff that supports us in what we're doing here. We know something about the tamsulosin and oxybutynin. What we know is he's actually got a long-term catheter. He doesn't need either of those drugs anymore. They're not helping, but they're what the Royal College calls, beautiful phrase, historic prescribing remnants. So out we get, let's get those out. We've talked to him, he hasn't had angina for years. That's true of a lot of older people who become very immobile and actually don't get angina. And we know that he's lost so much weight, in fact, that his diabetes is now pretty well almost in remission. And anyway, does it matter how tight his diabetes control is at this age and stage of life? We've got lots of evidence to show that actually we can relax that control, and that tight diabetes control is going to cause George problems. And we can give him some different medicines for his arthritis. And I say, well, what about the aspirin? He says, oh, Dr. Pollock, you've got to be careful there, because a cardiologist put me on that when I had a heart attack, and they said I had to take it for life. Okay, but because of the aspirin, he's getting bleeding from his stomach, and so he's being given lansoprazole to try and sort that out. And despite that, he's still getting iron deficiency anemia, and he's needing iron. And that means he's on extra tablets that are making him constipated and adding to his treatment burden. Is it worth George taking this medicine? This is about shared decision making, and one of the things I can do for George is to show him some beautiful work done by a GP called Julian Treadwell in Oxford, who has developed a website called gpevidence.org, and it's an absolutely fantastic way of showing patients what the pros and cons are, and showing ourselves, frankly, what the pros and cons are of different medications. And here is the one for aspirin. Everybody who's had a heart attack gets put on aspirin or clopidogrel or something like that forever. But actually, for a lot of people, that's exactly the right thing to do. If you're in your 50s or 60s, of course, that's the right thing to do. You need that. But when you get to George's age and stage, and we look at this number, and we think, how long has George got? What does his prognosis look like? We can suddenly realise that for George, this tablet is not worth taking anymore. It is not a good enough tablet for him. And this is not about whether George is worth it, it's about whether the tablet's worth taking. Similarly, as I mentioned, with the sugar levels, I find these all the time in hospital. Our patients are being, I can almost not bear it, but we can talk about it another time, having their sugar levels tested and monitored and tested and monitored and tested and monitored for weeks on end, and it makes absolutely no difference. It is just making somebody miserable. What George needs is a Jaffa cake and be left alone. And for quite a lot of my patients, there will be nothing in this drug box, the locked drug box, and there will be some good emollients, some laxatives, and something nice to drink. Of course, that's not true for everybody. I don't want to sound nihilistic. There's lots of good treatment out there, but a lot of our difficulty is because of this problem of polypharmacy. I'm just going to talk about another subject briefly. What are geriatricians for? This is a beautiful bit of work by America's got hardly any geriatricians, but the ones they've got are very good. Mary Tonetti is a fantastic professor, almost retired, of geriatric medicine. And she was asked, and she's done a huge research output, particularly in falls. And she was asked what geriatricians do. And it took her a while to work that out. And she came up with these 5 M's. So we deal with the mind, with dementia, delirium, depression, the big horrible D's. We obviously deal with mobility and independence, with that medication, with multi-complexity. So this isn't just people having lots of conditions at a time, which they do, but also what she calls the biopsychosocial aspects of their lives, how they fit into their family, into their community, who's helping, what support net mechanisms have they got, what happens in a crisis, what makes, and then most importantly, of course, is what matters most. So here's another statistics question for you. And I hope this is all right with you, because this is a slightly difficult question. So, or if you think about your local hospital, which is a very good hospital tonight, and you think about all the adults in that hospital as patients, 18 or over, not 80 or over, but 18 or over adults, not the obstetric ones, not the ladies having a baby, and not the psychiatry ones, but everybody else in the hospital, all your hips and knees, the elective surgery, the appendixes, the road traffic accidents, everybody in hospital, what percentage are not going to be alive by the 16th of January 2026, i.e. next year? What percentage of people in your hospital on one night are going to have died by this time next year? And I think lots of us come up with lots of different ideas about that. You may be guessing, so I might hear somebody guessing 5% or 2%, or maybe a bit more than that, depending on where you work. And this was a huge study done in Scotland about 10 years ago, and repeated again in Scotland, because I don't think they could quite believe their findings, and repeated in other hospitals all over the world, in Australia and Denmark and Austria and many different places. And the answer was about 28%. So somewhere between a quarter and a third of all patients in hospital on any one night will have died within the next year. And which of them are the ones who are going to die? It is, of course, going to be older people, men more than women, acute medical admissions rather than elective surgical admissions. So if you're an over 90-year-old man in hospital as an acute medical admission on any one night, you have an over 50% mortality, most of which will be within that index admission. And that, when I first learned it, made me sad. And then I realized that actually it isn't sad. It's really important. Everybody will come to the end of their life, and the important thing is how they get there. And it's about getting this right. So I just want to talk briefly about Gerald. Here he is, 87 years old. He's been at home. He's fallen. His wife couldn't get him up. He's confused. He's got a cough. The ambulance men find him, the paramedics, sorry, not men, find him frail and thin. He's got no blood pressure, very low oxygen, and they bring him to ED, where he has a chest X-ray after a little while. That shows pneumonia, and they've already given him some antibiotics very quickly. He triggers all sorts of sepsis proformas, and in he comes into hospital. And he's pitched up on our ward, and it's the evening, and he's on AMU, and I can see him lying there in the bed, and I hear this story, and I have got to do one thing. And the thing I have absolutely got to do, because Gerald is not able to speak for himself, he is really unwell and very confused, I have got to talk to his wife. So we speak to his wife, and the first thing we find is that he's not called Gerald. Hasn't been called Gerald since he was a baby. He's called Harry. He's a medieval historian, and he's had pretty nasty dementia for the last few years. He's been in a care home while Iris had her hip done, but she actually discharged herself from hospital to go home and rescue him because he was so miserable there. And he's been in and out of hospital in the last few couple of years, and more recently, and he gets chest infections, and each time he comes out, he looks less well, he's lost weight, he's got problems swallowing. And a lot of people don't realise that dementia is not just a condition of the mind. In the end, it's a condition of the body as well. So people with dementia often develop sarcopenia, loss of muscle mass, and that includes the muscles of your throat, which do your swallowing. And he's likely not to be able to swallow very safely. And every time he gets a chest infection or pneumonia, that weakness is compounded. And he has fallen a lot. And I say to Iris, can I ask you what makes Harry smile? What does he like? And she says it's a bit difficult to say now because he doesn't do very much, but she thinks he likes watching the birds, and nowadays he sleeps a lot. And one of the conversations I then have is there are different phrases that people have, and lots of people have these conversations really well, and all of us find our way to a different phrase that we can use. But what I might say to Iris is, Iris, I really want to do the right thing by your lovely husband, and I'm not sure that what we're doing right now is the right thing. And then there's a pause. And Iris says this to me. She says, he would not want to live this way. And when he was still speaking, which is over a year ago now, because it turns out Harry actually hasn't spoken for a long time, he's told her, if I could, I would walk into the hills and not ever be found. And at that point, I make a suggestion that we could do things differently, and that I think he is coming to the end of his life. The antibiotics may keep him alive this time, or they may not, but actually, I don't think it's the right thing to do. I think it would be very reasonable to stop those antibiotics and to keep him comfortable. And Iris says, I think that's exactly right. And she says, I agree with you. I'm glad we can just keep him comfortable. So I'm making a new plan, and I've got his end of life care form out, and I'm holding the phone under my ear while I am writing the form. And as Iris is saying thank you and I'm saying goodbye, she says one more thing. She says this, I know this conversation is just between you and me and no one else needs to know. And at that point, my heart turns over because I realise that she thinks she's done something wrong. And she thinks she's done something that is illegal, immoral, against our code of conduct, or is something that she should be ashamed of. So just briefly to clarify, because we've got ourselves in such a muddle with the assisted dying debate, this is the current guidance about end-of-life care, and most doctors do know this. We start with a presumption in favour of prolonging life, all reasonable steps to prolong a patient's life. The very next word is however, and an awful lot of people have not read that bit. We have to understand that bit. There is no absolute obligation to prolong life, irrespective of the consequences for the patient and irrespective of their views. If they're known or can be found out, how do we find them out? Speak to Iris. So this brings us on to another subject, which is advanced care planning, which is allowing people in later life to make the plans that allow them the ending that they would like to have. It captures what matters most, and I just wanted to show you some from Somerset. These are obviously mock-up anonymized ones, but here is Ken's. At the top it says, my personal priority is what's important to me at this time of my life, and it's got a resus decision and it's got decisions about coming to hospital, and you may use one of these or you may use the respect document. But the important thing about Ken's is it says, my budgie Olive, I know Connor will look after her when I'm gone, and it says he doesn't want to come into hospital. This one says, my lovely hairdo. The girls do it every day. Eileen has dementia and is unable to contribute to this conversation, but her niece and care staff feel she would not want hospital treatment, even if seriously unwell. Jerry says, I want to be at home at the end. I enjoy eating, especially a Warren's pasty. That's really important because I'm not going to make him nil by mouth. Roy says, I want to have all reasonable, all treatment that would stand a realistic chance of prolonging my life. Fantastic, Roy. Come on in. The hospital is open. We are here for you, and you've made your wishes loud and clear. And Brian says, being able to put my arm around Christine. And he doesn't want to leave his care home. These are really important. We need a national campaign to sort them out. We need them to be shared properly. These are about life, as you heard. None of these are about where I want to die. This is about what's important to me and what's important about my life. And they are about what I would call unassisted dying. And when we get that right, lots of other things fall into place, and we get our care right, and we start framing everything we do around what's important to our patients. So just to finish, I want to have a little bit of a think about what we need and what we can achieve. There is a wonderful cry from the British Geriatric Society for age-attuned training for everyone. And amongst that, there is a need for a huge shift of power from people like me, the doctors with far, far too much power, to our patients. We need to share information in a way that makes it easier for people to understand what their options are and to make their own choices. We need escalation plans that are valid and realistic and universal. And to do that, we need time and courage and honesty. That's part of it. Within that training, obviously, we need masses of training for people to be able to recognise the common conditions of ageing, things like delirium and falls, things like problems with bowels and problems with waterworks, and make sure that everybody understands the basic steps that need to be taken. We need to make sure that we call our patients by the name they want to be called. What things make, on a broader scope, what things make life better for older people? Well, I suspect you may be sitting at home thinking about what would make life better for older people, and here are some of them. So, housing that isn't too expensive, that you can afford to heat, that you can get around in, decent transport, public transport that's affordable and that turns up on time and that you can get onto if you're using a walking frame, healthcare that is designed around you and doesn't call you back to the hospital 3 times in a row for different scans and the results of them. And of course, libraries and interests and activities and concerts and choirs and community activities and green spaces. It's very easy for us who live in rural environments to forget how important greenery is, and of course, young people. But when I mention that to other people, one of the really important things is to remember what makes the things that make life better for young people. And of course, it turns out it's exactly the same things. So this is not about taking away from one sector of society and giving it to another. It is about making life better for everybody. So good housing is important for young people. Transport's important for a mother with a buggy and a baby. Healthcare is important when you're trying not to miss school or miss work. And older people are important for young people. Why? Just to say, because. Lots of reasons, but here's one of them. Younger people nowadays are exposed all the time to images of perfection, to a demand for perfection. And they are exposed to the idea that you have to have, from going to primary school, your first SATs have to be perfect, and your next SATs have to be perfect, and you have to have the perfect GCSEs, perfect A-level, perfect job, perfect boyfriend, perfect body, perfect teeth, perfect holiday, perfect infinity pool. And older people know that life is not like that. And I think about one of my patients who was a fantastic woman. And I said to her, Jane, you've obviously had an amazing life. And she looked at me and she said, Dr. Pollock, it's not been all roses. My first 2 husbands were complete shits. And then I got a keeper. And what one realizes, of course, that older people understand that life genuinely is a roller coaster, that you can have terrible bad times, you can have bereavements, you can lose a child, you can come out of an abusive relationship, and you can recover and life can improve and good things can happen. And there's some beautiful research behind that from a chap called Marshall Duke in Seattle, looking at the fact that children who know the story of their grandparents, who know where they met, and who particularly know something about whether they overcame difficulties in their lives, such as bereavement or having to flee from a war or a bankruptcy or a house that burned down. Children that know those stories are happier and more resilient themselves because they can understand, they've heard a story of recovery and recuperation. And I'm going to finish in just a moment. But what I want to say is, this is for all of us. We're all learning to be older people, and we can treat older people now as we'd wish to be treated, and we can listen. And that is where I am going to stop and suggest that there might be some questions. Okay, and I'll stop sharing there.
Thank you, Lucy. That was really lovely. And I'm sure we will be getting some questions in. If people would be kind enough to type their questions into the Q&A option that is the bottom of their screens, and we'll start taking your questions as they come in. Maybe, Lucy, I could start by asking you, in your book, you comment about how today we're simultaneously connected to everyone, but yet to no one.
Mm.
Would you kindly comment on social
Yeah.
prescribing and
Oh, wouldn't I love to, James? It's so important. So we know that we have an increasing epidemic of loneliness, and that is true in the States, where the Surgeon General made it his report of 2022, I think, an appalling increase in social isolation and loneliness. And the statistics this year about how many people in the UK were going to spend Christmas on their own, especially young people, which is really sad. That is a complete change in our society. And so somehow we have become very fragmented, and it's partly a respect for autonomy, and but it is also this fragmentation of families and communities. And we recognize that that plays into ill health in so many ways, in not just mental illness with depression and anxiety, but also, which is a self-perpetuating vicious circle, but also in terms of people's physical well-being. So social prescribing, I think, is really gathering momentum, and I am a huge fan. It's very difficult to get the evidence base right there, because performing a granular placebo-controlled RCT is extremely difficult in social prescribing. So we have to accept that the science will be different. But this is things like a GP being able to say, I'm going to send you to see somebody who is going to listen and work out what's important to you, and what we can do to help. And this is not about signposting, this is about genuine help. So lots of social prescribers will walk with somebody to their first appointment with a community choir, will take them to their first appointment at the gym, and maybe the next one as well, to improve their chances of going. So it requires investment, but I have absolutely no doubt it pays off. Also, the people who know what's going on in the community, these incredible village agents. I don't know if you have them in Wales, but we have them in Somerset. I love them. They are often women of a certain age who know their community absolutely backwards, and they know the little groups who meet and where somebody will fit in and find companionship and hope. I think I am really delighted that it's been recognised for sure. If we haven't got any questions, which I can't see.
Yeah, we do have some. If I could just pick up a few of those for you.
Yeah.
There's a question here that, are there any protocols to prevent cascade prescribing? Is it being taught in universities?
Oh, okay. A really, really good question. Pharmacology is taught at universities, but probably not enough. And I know every area of medicine always wants more of the curriculum. But pharmacology is so important now, and it is complicated. And recognizing poor prescribing and there are lots of hitches. It isn't just prescribing cascades, but it's also unnecessary drugs that aren't helping, drugs that aren't stopped, and so on. So polypharmacy is a very big subject in the undergraduate curriculum, and is through the next bits. But it is easy for everybody to think it's somebody else's problem. We're all so busy that it is very tempting not to change things. Also, we all suffer from being worried about stopping something that somebody else started. And I have to say, I hope the cardiologists will forgive me. They are the kings, and nobody wants to stop a drug that's been started by a cardiologist, apart possibly from the odd really gutsy geriatrician. So we have to be very brave about that. What we need to recognise, for example, we can talk about science, most trials of big medicines, big important medicines, do not include older people, or if they do not include older people with significant frailty. So they're designed to exclude the very patients that we now give those drugs to. And then we're surprised when they run into a whole load of side effects. So it's really important that we increase the science of how to look after people with more than mild frailty. So we've learned how to measure frailty now, we can categorize it, we can put people on a scale of frailty, and that means that we can now really work out who is going to benefit and not. But we're not there yet. We've got masses of work to do. What I would recommend anybody interested in is to do more training in polypharmacy. There's a superb English one, I don't know if it's going to be available in Wales, called Action Learning Sets in Polypharmacy. And I would strongly recommend them there for GPs and prescribing. There are fantastic pharmacists out there who know their stuff. So prescribing pharmacists are a very, very good resource, and they're learning this complicated stuff as well.
Great, thank you. So we've got one individual on the call this evening. I'm a final year medical student interested in geriatric medicine. Can you give me some advice, please?
Oh, stay interested, enjoy it, enjoy it. So what would I say? Don't get despondent. Enjoy meeting your patients. Read books. You don't need to read medicine books. Read books about life, because medicine, so much of geriatric medicine is about life. So if you're interested in reading poetry and literature and going to plays and stuff like that, that might not be a bad idea, because understanding human beings is a really important aspect of geriatric medicine. And what else would I say? Don't worry if you do a geriatric medicine job that you don't enjoy, because not all departments function as well as some of them are better than others. I worked in a terrible Jerry's medicine department, I would say, where a long, long, long time ago as a very junior doctor, it completely put me off it. And it just happened to be falling apart. But it didn't represent the others. So if you have one bad one, don't let that put you off. And please do it. It is the future. And what I would say is I see some of the brightest and best young doctors going into geriatric medicine now.
Excellent. What can doctors do to help destigmatize aging and discussion around aging and diet?
Yes, okay. This is a really big one, and I think we're on a big trajectory about this. I think there are some doctors who are writing beautifully about aging and dying. For example, Catherine Mannix, and I would strongly recommend anybody in the medical field, you need to read With the End in Mind. It is a superb book. I had to read it one chapter at a time because lots of it's very sad, but it's beautifully done about dying. I would read her other book, Listen, which is fantastic as well. I think, and they're good for the general public. I would always recommend people read Atul Gawande. Being Mortal is a superb book. And I think also, though, what can we do as doctors? We can talk about it. I talk with almost all my patients about what's going to happen in the end. We can learn to frame those conversations and have those delicate, and I use the word delicate. I say, I'm going to ask you a delicate question. And I say, do you know, I've forgotten how old you are now. 87. Okay, that is a good age. Do you know, when you're 87, you never know what's around the corner. And my patient will nod and they know what I'm going to talk about. And almost always they are very relieved to have a conversation that puts a framework around what they want. Not everybody, some run away, but most older people are really relieved. I don't let the younger people shut that conversation down. I won't have a daughter or granddaughter lean across and say, oh, we don't want to talk about that, and if an older person says, I don't think I'll reach my next birthday, or I think I might be coming to the end, it's really important that that conversation is had. It's so essential. I think we just need to normalize it. Everybody should have a treatment escalation plan if they've got a long-term condition that could suddenly deteriorate, or I would say anybody in their 80s, 90s. It's unbelievable how many people I see who've seen hundreds of healthcare professionals and have got crashing end-stage heart failure, end-stage dementia, end-stage Parkinson's disease, cancer with mets everywhere, and nobody has spoken to them about a treatment escalation plan, and that means they are for resus. That's awful. I think it's actually unethical, and so let's change that.
Yes. An interesting question. What sort of activities do you think best promote intergenerational relationships, bringing young and old together?
Oh, I love that. That is such a good question. Where do I see old and young working well together? I see it in libraries. I see it sometimes in older people who go in to help children read. I think reading is the most phenomenal thing within a family or in a school setting, where older people and younger people can roar with laughter over a children's book. Fabulous, going on a bear hunt, you know it off by heart. And so I'd say that one. I love choirs. I love community choirs. You see older and younger people in a setting together. Sometimes you see it in cafes. You sometimes obviously see it in religions, sadly less frequently now, but there are churches which are very integrated and are very important in people's lives. What's taking the place of that? Community activities. There are some fabulous ones. There's one down near here, which is a real all-age range outdoor sort of daycare-y kind of activity for people with mental and physical problems. Fabulous, all funded by charities. So look around for them and embrace them. And if you're the only older person in a group, doesn't matter. Get in there, have fun, and enjoy it. And if you're a young person and you go along and everybody's old, you think, oh, well, go me, don't I feel young? So it's a nice feeling being the youngest person in the room.
Indeed, indeed. Lucy, there have been some unfortunate stories in the news recently of exploitation of lasting power of attorney.
Oh, yeah.
I don't know if you picked up on the,
Okay.
yeah,
Yeah.
and this particular individual that was mentioned. He was not a qualified solicitor, but nevertheless, he was partnered,
Mm.
and he was clearly, yeah.
Yeah. So yes. So LPA is really important. I would encourage most of my patients to have at least lasting power of attorney for finance set up. That's the one that really makes a difference in terms of practicalities for your family. And I think that one is worth making. The one for health and well-being, I feel, is a less useful document, to be honest, because the really important thing about best interest decision making, and we don't get this right all the time, we should, is that if you're trying to make a best interest decision on behalf of somebody who can't speak for themselves, hasn't got capacity for that particular conversation, you must work out what is in their best interest. And the only way you can do that is by talking with their family or people who know them and finding out what their views would have been if they could speak for themselves, not what the family's views are. It's not what you want for your dad, it's what he would have wanted for himself. So actually, it's really important that we don't think that just because a family doesn't have LPA means that they can't speak. They have, it's a really important role. So that's a misunderstanding. But the finances one, yes. So if somebody, we haven't spoken about people aging without children. It's a really interesting group of people. It's a very rapidly growing group of people. So we're always talking about families, and actually there are lots of people who do not have family. And they will often turn to a solicitor. I think you need to do your research with the, and I've now briefly forgotten what they're called. They're called solicitors for the elderly, or at least that's what they used to be called, and I think they've got a different name. And there is a sort of approved group of people who've done some extra training and work with older people and are generally scrutinised quite carefully by and they are trusted. So that's where I would recommend that people go. I think it's awful. I mean, there are bad apples in anything, aren't there? But awful that there was and there probably are others out there who are not good players. But I don't think that ruins the whole thing. I think it just means we have to be a little bit cautious about what's going on.
Yes. I've got one here, Lucy. What advice would you give to an A-level student who's worried about getting the grades for medicine, really is his or her dream job?
Oh, love. Okay. Um, yes, it is. It's tough, isn't it? And it's not just the grades, it's the whole ACAT or whatever it's called, and all of the hurdles that you have to get through. If it's an absolute dream job and you're set on it, you will almost certainly get the grades one way or another. And I'll tell you a story. I've got a couple of minutes. A colleague of mine, who I love very much but won't name, didn't get the grades that she needed to get into medical school. She missed one of them. And she rang up and they said, no, you've missed the grade. You'll have to resit your A levels or you can't go to medical school. And she was in despair. And she got on the train aged 18 up to London, and she went to the medical school that she had been turned down from. And she said, I'd like to speak to the admissions dean. And the secretary said, no, you can't. And she said, well, I'd like to. And he said, the secretary said, well, you have to write him a letter. He's busy. So she sat there writing him a letter. And then the secretary left to go and get lunch or something. And she saw that he was in his office. So she nipped in and she said, I really, 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 really want to come, and I'm really sorry. She burst into tears. I'm so sorry, I missed it. I didn't get the maths one. And what am I going to do? And he said, well, you have to retake it, and it's all right, have another go, and so on. But you will have to retake, and you didn't get in, and rest of it. Anyway, she got a letter 2 weeks later saying, you're in. We've changed, we had a gap, and in you come. And in her first lecture, he called her out her name, and he said, I'd like you to stay there. And he said, you're going to have to work very hard because you didn't get the grades, but also you were so overwhelmed when you came to see me that you didn't actually tell me your name, and I had to go through all 400 photographs to work out which medical student applicant you were. But you were the only one who contacted us and said, I am desperate to come in. So that's a story of encouragement. I don't promise it's going to work. But what I'd say is be calm. I suspect you're going to do fine. Do the work. Don't get in a panic. If it doesn't happen, it's not the be all and end all. And I know lots of people who didn't get into medical school who say, thank goodness for that. And I'm happy in a different role, and you will find your role in something else. But life generally turns out the way you want it. But I'm glad that you want to do medicine.
Great. Lucy, I'm going to finish up with one more question for you, and it's how do you handle the death of the people you help? especially when you build a relationship with them. The emotional aspect to most career in medicine does worry me.
Yes, you're right. You're right. And I went through a phase in the middle of my career where I was doing a lot of stroke medicine, and I found that very difficult because people's lives were so turned upside down in a moment. And I noticed that I became a little bit too close to some of my patients, particularly if I was touching them, if I was smoothing their hair away that had fallen across their face and they hadn't noticed, or helping them put on a slipper or something like that. And I suddenly could feel my empathy getting draining. And what I learned, and I had some counselling. I strongly recommend when you're in trouble in medicine, you need to call for some help. I've had some very good counselling over the years. I can't recommend psychotherapy enough. I'm married to one of them, and so I've got a vested interest there. But I learned to put a little divider between me and my patient. You can have empathy, you will drain. Compassion, you will never drain. Okay, so you can have a bottomless fund of compassion, and you don't need to have a bottomless. Putting yourself in someone else's shoes isn't always the best idea. So being compassionate, but not having an endless supply of empathy is fine. And one of the things that I did was visualize for myself a sort of Harry Potter, no, Star Wars kind of wand thing that I could deflect this sort of flow of negative energy. Or sometimes I think about a silver teapot, and on a metal teapot with a metal handle, you often have this little ring of bakelite or plastic or whatever to hold the heat away from the handle, and the handle stays cool and functioning even when the pot is very hot. And there are times when I still go back to that image and remember it. But that's a very, very good question, and just the fact that you recognize it is going to be protective.
Thank you again, Lucy. So Lucy, I wish you could see some of the comments that are coming in, because they're all saying what a fantastic presentation it's been this evening. And they're all rather hoping that they'll be looked after by someone like you when they reach old age.
Well, they will. I love geriatricians. They're great. It's the biggest specialty in the UK now. We've overtaken, and the training is superb, and I think the future is bright for geriatric medicine.
Yeah, I know it's a high priority here in Cardiff as well, and some of my colleagues are on the call this evening.
Brilliant.
So Lucy, it just remains me to thank you once again for a wonderfully engaging talk this evening. If there's probably one lesson to take away from this evening, is that the aging process is something to be celebrated. So thanks again for highlighting that to us, and once again, wonderful lecture this evening. Much appreciated.
Thank you so much. Thank you very much. That's very kind.
So, my colleague Karen will be contacting this evening's participants to try and obtain some feedback as well. So please watch out for that text that will come through very shortly. But thanks once again. We are back again next month. We have Professor John Aggleton from Cardiff University, who's going to be presenting on amnesias, real and simulated. So that's Thursday, the 6th of February. So thanks, everyone. Much appreciated. No start. Thanks again, Lucy. Bye-bye.
Thank you. Thank you. All gone.